Welcome, and thank you to everyone for joining us today for this discussion about making the most of opportunities across global health initiatives with a view to improving survival and quality of life for all women with ovarian cancer. But more generally, this discussion will, I think, hopefully open doors for opportunities to empower women and improve their experience of health and cancer more broadly. My name is Clara McKay. I'm CEO of the World Ovarian Cancer Coalition. We're a network of 200 patient advocacy organizations working worldwide. So this topic is really important to us at the coalition because we are committed to improving outcomes for women with ovarian cancer, but also because while many of the advocacy organizations we work with are ovarian cancer specific, many, many more are tackling the disease from a wider perspective that includes women's health, gynecological cancers, women's cancers, and generic cancer. And I'm pleased to be joined today by some of these amazing advocacy organizations that we have the good fortune to work with. So there are a number of global initiatives, including the Cervical Cancer Elimination Strategy and the Global Breast Cancer Initiative, that are impactful and where much thought and much resource have been invested. We know there will be useful insights from these initiatives and potentially some really practical lessons about touch points on the ground and within healthcare systems where opportunities exist to connect with, educate, and empower women about ovarian cancer. I'm delighted to be joined today by an outstanding panel that include Nicoletta Serrani from the Italian advocacy group ACTO, Lauren Pretorius from Campaigning for Cancer in South Africa, and Maud Wakasangila from the Women's Coalition Against Cancer in Malawi. Also, a very, very warm welcome to Dr. Ben Anderson, Professor of Surgery and internationally recognized leader in cancer control. Dr. Anderson leads on the Global Breast Cancer Initiative. Welcome also to Miriam Mutebi, who is a breast surgical oncologist and current chair of the UICC International Task Force on Cervical Elimination in the Commonwealth. Dr. Sharon Kapambi, also a physician and global public health cancer expert. And finally, but not last, Mary Ican, CEO of the International Gynecological Cancer Society. Welcome all. So I'd like to start this discussion from the perspective of women and the advocacy on groups on the ground that represent their interests. And Nicola, if I could begin with you. I know that until about 2 years ago, your organization, ACTO, focused specifically on ovarian cancer, but then took the decision to broaden your remit to include all gynecologic cancers. And I'm interested in that decision. And can you tell me what factors led to that decision? And also from the perspective of women in Italy, why did it make sense to broaden your approach to capture all gynecologic cancers?
Good evening, everybody. Thank you, Clara, for the question, because it's a topic very important for our association. In fact, we were born in 2010 to support Italian women with ovarian cancer. I'm talking about 50,000 women and of about 5,000 diagnoses per year. However, over the years, 12 years of working, we have come to realize 3 important facts. The first one, the lack of Italian advocacies dedicated to gynecological cancer. This situation often has led many women with gynecological cancer other than ovary to join ACTO to take advantage of the services we offer to support the patient quality of life, the information. I'm talking about update meeting, yoga courses, writing workshops, etc. The second factor was the very little knowledge that the Italian women have of all gynecological cancer, despite of the incidence of these diseases, because in Italy we have about from 230 to 150,000 women living with gynecological cancer. And the cause of this ignorance, in my opinion, is to be attributed not to economic condition, but to a very low health literacy of Italian women. And a recent European research carried out on 17 European countries measured the health literacy, and the 31% of Italians showed insufficient health literacy compared to an average of 23% of the other countries. And the third fact is that in Italy, ovarian cancer and other gynecological cancer are treated in the same highly specialized center. This means that women with ovarian or other gynecological cancer access to the same hospital. And these three facts convinced us to expand our mission from ovarian to all the other gynecological cancer. Because we needed to fulfill a void of a representation, to fulfill a void of information in terms of prevention, diagnosis, treatment, and to expand patient quality of life support services.
Thank you. I'm very interested in in all of those 3 points, because I think they make a very compelling case, and I find the health literacy point really, really interesting. Actually, it's just a very interesting way of coming into it. And Lauren, if I could bring you in now, you in South Africa, you've taken on an even bigger challenge. So your organization, Campaigning for Cancer, deals with all cancers, and you work with a huge range of stakeholders, including governments and policymakers and healthcare systems, industry, and of course, patients. And I'm interested on your perspective on this, about opportunities to either break down or silos or take advantage of kind of single system approaches. And I'm also interested in your perspective on whether funding or policy, global policy initiatives impact on how well or how not well you can leverage opportunities to advance the interest across all women's cancers.
Thank you, Clara, and thank you for inviting me to be on this esteemed panel this evening. Well, it's evening in South Africa. So when it comes to looking at breaking down those silos, I think it's important to understand that in a country like South Africa, we have a lot of disease burdens when it comes to it. And a majority of those disease burdens are historically seen as communicable diseases. So we've had a healthcare system that's built for communicable health systems. And when you talk about the international policy, a lot of that healthcare system was funded by international grants. And what's happened is, because of the way and the structure that those grants are created, it's almost created a silo and a separate healthcare system. And I look at examples where we were looking at palliative care for cancer patients, and because the hospices were getting funding from an international organization for HIV, they couldn't have cancer patients in their hospices, which is, so sometimes those are the on the ground issues that we can see. When it comes to breaking down the silos and why Campaigning for Cancer looks at a multitude of cancers, in a small country like South Africa, relative to the rest of the world, we have very few advocacies. In fact, Campaigning for Cancer was one of the first in South Africa in 2008 when we were formed, and so it demanded that we start looking at all the cancers. And there's a saying in our office: how do you eat an elephant? One bite at a time. And we constantly have to do that. But a few years back, and in fact it was a gentleman with lymphoma, but it's something that I tell, and I hope that it reframes what we look at, is he was a lymphoma patient, and he had spoke about how he'd hurt his ankle and how he'd had sight issues from his treatment. And he said, my oncologist sees me as a lymphoma. and my ophthalmologist sees me as an eye, and my doctor for my leg sees me as a bone that's broken. And I'm all those things. And I think when it comes to women's health, we have to remember we are all those things. We as women, there are opportunities in South Africa because we have such an amazing system and resources when it comes to communicable diseases. We can look at tagging on diseases like HPV testing. If you're testing for HIV or that person has tested positive, then let's look at HPV. If that person has tested, has had a breast cancer, let's look at talking about ovarian cancer. Let's look at from an age point of view. If we look at maternal health, the one way that women are always going to be in the healthcare system is when giving birth. It's often sometimes the first entry for countries like South Africa that woman will have entry into the healthcare system. So why don't we keep that woman and look at the diseases that affect her or the conditions, pregnancy and so on, but later in life, if we're looking at ovarian cancer and so on. So there are huge opportunities. I think as we move closer to universal healthcare, it's beholden on us to mesh those opportunities together and leverage those opportunities, because there isn't enough time, there aren't enough resources, and there isn't enough engagement in doctors for us to silo these things. And I always remember that patient Graham saying, you see me as a cancer, you see me as a leg, you see me as an eye. I'm one patient. I have all these things. You need to see me as a patient and my health.
Wow, I think that's so interesting, actually, that, and in a way, an emphasis on some very worthy and important health areas like HIV can have that knock-on effect. And we'll come back to talk a little bit about maybe why and how that happens. But Maud, I want to bring you in now, and your organization, the Women's Coalition Against Cancer in Malawi, you've done just inspiring work in cervical cancer by training healthcare workers at antenatal clinics. So to Lauren's point, about cervical cancer and the disease, so that those healthcare workers have the knowledge to talk to women about cervical cancer screening. And I know that your organization also does amazing work reaching out to women in rural areas with messages about the importance of screening. And I want to start there because I think because of that specific work, reaching out to women in rural areas, I wonder if you could provide some insight about the practicalities from a woman's point of view of just accessing healthcare services and dealing, the experience of dealing with different healthcare initiatives that are coming in from different directions.
Thank you very much, Claire, and great to hear about the other panelists who have come before me. Okay, when we're looking at healthcare for women, it is a bit different when it comes to maybe the communities or we work in. Like when a woman comes to the health center, she comes for one thing, and then you're able to say, okay, when she's already there, you're able to help her with other things. So what actually happens is that at this point in time, you find that there's more talk on cervical cancer and maybe breast cancer. So when these women are coming to the hospital or to the centers, what we're doing right now is just addressing these two things. And it's the government looking at the disease burden or the prevalent cancer at that point in time. So that's what you're going to talk about. So at the end of the day, you're going to concentrate on this one thing, which all the women, all the country, the whole country is talking about, all the health centers are talking about. So you end up addressing that issue and then find that there are other issues which you're not actually addressing. So it's all about the challenges coming because you're only looking at one thing. Here's a woman's already at the hospital who needs attention in different areas. The other thing we find as a challenge is the language, which we have to explain these cancers to them. When you have things like cervical cancer, it is something they might know. Breast cancer, it is something they can see. But to describe like ovarian, which part of, because we're dealing with women in the rural area, for them to understand that there are other parts of the reproductive system which can also be, they can actually have cancer from that. So it takes a bit of time to get that language where we can actually get it to them and to make them understand. So you find that maybe what we're trying to do is just concentrate on maybe breast and cervical cancer, but ovarian and all the others are very important for this woman to know. The other challenge would be like maybe funding. So you get funding. What you get funding for is for cervical cancer. So what do you deal with? You cannot talk about breast cancer when you've got funding for cervical cancer. But it would be right and nice for the person you're going to see at that point in time in the community if you could do all these at the same time. Because at times you go with different messages, and here's a woman who doesn't understand. They don't understand cancer on its own as it is. But now when you start breaking down, you go one day, you go with cervical cancer, and then you go another day, oh, there's ovarian cancer, and then you go another day, there's breast cancer. But it would be something nice if we could get that kind of funding where it's all put in together and you're able to talk about these different types of cancer. You're talking to a woman, you maybe talk about STIs, talk about pregnancies and everything. Then you talk about cervical cancer, you talk about anything that concerns her at the same time. So you're able to make them understand at some point in time instead of going with different messages at the end of the day. So when you're looking at that, because these women start saying, how many cancers are there? You keep telling us there's this cancer, how many cancers are there? So you can't even introduce a certain cancer when you've only got funding for example, for cervical, you cannot introduce breast cancer. So I think holistically, a woman to be helped, that all this information should be given to her. You know, messages which she should be able to get all these messages at once. And you know, when these women get it, the good thing about women in these communities, when they hear a message, it's very easy for them to they internalize it and know that this is what I heard. And because I heard this, maybe I have some signs on this and whatever, let me get help from a health center. So I think that is something which is very important that we should look at. And another thing is that maybe at times you find that there are signs and symptoms which kind of collide and they're not too sure. But when they are told what they are, and also the health workers are also educated, because it also becomes a problem. You might go with all these kind of cancers to them and telling them, but maybe the health workers, because they don't have that kind of incident happening, they're not able to know if that is something to refer to the bigger hospitals, or they should be able to start working on it right there. So I think even the primary health workers need that education to know the type of cancers which are there, and they'll be able to inform all these women when they do show up some kind of signs, say, oh, this is what happens with breast cancer, with ovarian, so they're able to know everything and be able to inform the patients who come into the hospitals.
Thank you. And what strikes me too is, I'm thinking about, say, in Canada or the US and the UK, we also do have those siloed health care messages. It's you know, we all fall into that kind of pattern of working and potentially, I would say, are definitely from a woman's point of view. And I think you've touched on a really important point about healthcare workers' point of view, that you know, having a broader knowledge and not having to take on individual different messages and try and sort of, you know, make them all fit together in some kind of jigsaw puzzle. So I think that's really interesting. And so, Dr. Anderson, I'd like to bring you or talk to you now. And I kind of really want to come back to that point that Nicolette raised about health literacy. It just feels really important. And the objective of the Global Breast Cancer Initiative is to reduce global breast cancer mortality by 2.5% a year. And by doing that, avert 2.5 million deaths of women globally by 2040. And that's an ambitious target. But can you tell us a bit about the Global Breast Care Initiative? But I'm especially interested in the pillar of your strategy that is about health education and health promotion.
Sure. Well, thank you, Clara. It's really quite a pleasure to be able to be here today. I am now with the World Health Organization as a medical officer, and I'm the focal point for the Global Breast Cancer Initiative. And as you said, the objective is to reduce breast cancer mortality globally. And if we reduced breast cancer mortality by 2.5% per year, that, as you said, would save 2.5 million lives. There are these three pillars: health promotion for early detection. That's the initiative you're asking, the component you're asking about. The second pillar is timely diagnostics. And the third is comprehensive breast cancer management. Because when we think holistically, you have to think about systems. One of the limitations in improving breast cancer outcomes is how to make the healthcare systems function in ways that we know work. This is really a marriage of two ways of thinking. One is the public health sciences way, where we look at the populations as a group, and the other is the clinical way. How do we actually manage patients and walk them through the system? Let me be more specific. These graphs are mortality curves for breast cancer going from the 1950s up to the present time. And what you can see is that in beginning in about 1990, there was this dramatic reduction in breast cancer mortality. That actually was a 40% reduction between 1990 and the present time. This was in high-income countries. The question for the Global Breast Cancer Initiative is, how do we achieve this in low and middle income country settings that haven't seen that yet? Because we have to remember that everything that happened was today standard tools that we would consider. So how do we do this in limited resource environments? This looks complicated, but this is actually the path that patients walk through. And it would be the same if one is in Seattle, Washington, or Nairobi, Kenya. That first pillar, the patient enters the system, and that could be because of screening with mammography, but that's a real limited possibility because mammography is used and useful for women 45 and above, but it's also very complex to set up. Most of the time in limited resource environments, women are presenting with lumps or thickenings or symptoms. The second interval is the diagnostic interval, and this is often forgotten about. When the woman comes in, we have to sort out who has cancer and who does not. And this is similar with ovarian cancer because the symptoms are subtle and could be many things. So knowing when she comes in and you provide the education, what is going to happen? What needs to be in place so that the diagnosis is correct? And the third pillar is treatment. We're not going to talk about it in detail today, but actually finding the cancer only helps you if you then treat it. The pillar that you were asking about is this health promotion for early detection. The idea here is that we do need to educate the public. And as my colleague said before, we want to link these efforts together. Health literacy is fundamental, and it's true for all of the disorders that we treat. And we want to link them in ways that are effective. So if we're recommending that cervical cancer screening should be taking place between ages 30 to 49, that is an opportunity to simultaneously provide breast health education. The women need to understand what are the signs and symptoms of this, but more importantly, why would I come in? How does early detection actually help me? But that only works if we also address it from the system standpoint. So the providers need to recognize breast cancer. And if you've only been in a country where everyone is presenting with very advanced disease, how would you recognize early stage disease? So having educational modules and programs where we can walk the clinicians through to know how to trigger the system. And our goal in this setting is to have adequate early detection of cancer, which means that at least 60% are this early stage disease. And that is a fundamental strategy for moving forward. I will stop there. And since we've talked about the first pillar, and thank you very much for your attention.
Thank you, Ben. Thank you very much. And I do want, we talked probably a month or so, or a couple of months or so ago, and you spoke really eloquently about, and I think it's something Lauren actually touched on too, about the kind of common sense case for, integrating some of these cancers and work, and specifically in relation to looking at it kind of from the point of view of kind of it's one woman and often the same local healthcare systems and resources. Do you want to elaborate a little bit on that as well? You put it very eloquently.
Well, I'll take my best shot at that. But what I think is the reason we talk about different diseases is because that's how we think about it. But that is not the patient's experience. The patient has a cervix and breasts and ovaries and a GI tract. And so we want to have integrated strategies that are meaningful. But we also need a healthcare system that does that as well. If we think in silos and you say, well, I'm an HIV person, so that means I'm not a cancer person. That's a disservice to both, because actually it's the same infrastructure for the great majority of what we do. So how do we gear up this system so that it's prepared to handle these different disorders in ways that are feasible and sustainable within that environment? And that's very much the focus of the Global Breast Cancer Initiative. But if we do that, that is a health system strengthening perspective. Because if you can do breast cancer, which is the most common cancer globally, then if we can manage this disease, there are a lot of diseases we can manage. And it's not limited to cancer. It includes other non-communicable diseases, diabetes, cardiovascular disease, all of these fundamental strategies. So we are, in fact, able to lift ourselves by our bootstraps.
Thank you. Thank you so much, Ben. And Miriam, if we could chat to you for a bit. So like Ben, you bring insight that is both clinical, but also from a global initiative in your role as chair of the International Task Force on Cervical Elimination, Cancer Elimination in the Commonwealth. And I know you have seen and have spoken about, the barriers that need to be overcome to improve women's health in cervical cancer and in breast cancer. And I do know each country will be very different, but could you speak to a bit about the barriers that you see and the common challenges that exist across all women's cancers and women's health, perhaps?
Absolutely. And I think, as you said, there's lots of barriers, but perhaps the conversation is really around what are the opportunities. But sort of looking at it from a broader lens, we do know that in many countries, not only are women diagnosed late, they frequently did not complete their care. And if we look at the three sort of broad categories behind that, we see a constellation of factors that really rotate around the fact that patients are having to largely pay out of pocket, which frequently results in financial toxicity or catastrophic health expenditure. So really pushing the case towards looking at more universal health coverage models to ensure that we're having continuity of care. The other broad barrier is actually the health system itself, where we know, for instance, in sub-Saharan Africa, for instance, a patient will see on average 4 to 6 healthcare providers before a definitive diagnosis of their cancer is made, just really underscoring the points I think raised by Ben and Nicolette around really strengthening the health systems and the healthcare providers in order to be able to ensure timely diagnosis and appropriate referrals upstream. Again, of course, looking at the preparedness of the system, it's all good to screen, but if you're not able to, if the system is not prepared to handle the burden or adequately ensure that patients are going through the entire continuum, whether it's through prevention, early detection, treatment, all the way to survivorship, those are some of the concerns we tend to see. Again, one of the areas that perhaps we don't touch on as frequently is the social cultural barriers that exist, especially around access to care. And this is because we don't perhaps often think, we do know that in many parts of the world, women are not the primary determinants of their health-seeking behavior, and as such require either financial support or sometimes permission in order for them to access care. So it's really about reframing the question, reframing this as a equity issue, as a social justice issue. The other thing that we don't perhaps delve into as much are really the social cultural norms, where we have fatalism, where in many parts of the world, the narrative is that cancer equals death. And so people think, why should I, get care? And again, there's a collectivism, as I said, where decisions are made sometimes for the individual rather than the individual having agency. And again, the myths that exist, use of alternative therapies, beliefs that cancers are contagious or resulting in stigma. And so as part of the strategies that we're employing, we're just pleased, and I'm going to have a plug-in for that, is just recently at the Commonwealth Ministers Forum, we've launched a collaborative document from the task force that's really trying to hone in around myths and misconceptions across the that we frequently encounter as far as cervical cancers are concerned. And this is, again, the myths may differ from country to country, but they're certainly ubiquitous in the sense that approaches around vaccine hesitancy, and it's really giving healthcare providers and advocates the tools to have these conversations around in community spaces, in public spaces, in the healthcare system, to really encourage that dialogue that helps patients to enhance their health-seeking behavior.
That's really helpful, because my next question would be, based on your experience and observations and work in this area, do you have advice in terms of practical thoughts about how clinicians and advocates, so organizations like the World Ovarian Cancer Coalition and global policy initiatives can work together? Do you have what would be your advice to us in terms of how we can strengthen all of our hands by working together?
That's a good question, Clara. And I think, as you said, I think we've sort of referenced it throughout the rest of this talk, is about this operating in silos and really sort of broadening that opportunity for shared collaboration. For instance, the International Commonwealth Task Force is really a collaboration between advisors, which include people in academia, healthcare professionals, scientists, cancer advocates, and then, of course, with the Commonwealth and in partnership with the Union for International Cancer Control, which really has an umbrella of multiple NGOs and civil society organizations, and the WHO as well, providing their technical support. So it's really the integration of all these, and looking at rather sort of looking at patient-centric approaches, rather than sort of looking at how do I approach the cervix, as somebody said, how do I approach the ovaries, looking at what are the holistic areas. I mean, we've just spent a day at the malaria and neglected tropical diseases forum, and it was really telling in the sense that they've been able to engage all stakeholders, getting media on board. David Beckham was really talking about how we need to kick out malaria. Somebody was doing a dance and saying we've got new moves to combat malaria, but really looking at how do we engage and get innovative ways. And I think one of the ways that perhaps we haven't leveraged on enough is our youth advocacy, and that's a powerful tool, especially around women's cancers, where we know for certain reasons, older people, there's a certain taboo or stigma around sort of discussing these in public spaces. We recently launched the Youth Forum of the Commonwealth, that's really looking at peer-to-peer learning and intergenerational exchanges. I think will go a long way towards demystifying what is my ovaries, as somebody said, what happens, what should I look for, basic signs and symptoms, but really having that support across generations, because teenagers are going to talk anyway. So the question is, how do we tap into what they're talking about, and how do we ensure that the correct messages are coming through? And so it's really mobilizing our youth to push the needle in terms of broadening these conversations in all these spaces, I think.
That's interesting. And Nicoletta and I spoke earlier this week, and we talked a little bit about one of the plus sides of extending into a wider remit around gynecological cancer and talking to young women about cervical cancer and reproductive health, is that you start talking to women at a younger age than trying to target messages to women when they maybe reach an age where risk for ovarian cancer increases. So actually, the opportunity to start talking to young women and really kind of improving health literacy and awareness, I think
Absolutely.
is a really
Absolutely. And it's all about the messages, because it's not just get your cervix screened. It's really the conversation around how do you get agency around your body? How do you take charge? I think goes a long way towards sort of now rebuilding those messages upstream. Yeah,
exactly. I agree. And I think it's about, if you're not empowered to do something with that information, it's not always effective just to be downloading messages about symptoms when as you say, women may not have the agency to act on them. And I want to talk to Sharon for a little bit now. Sharon, welcome. Thank you very much for joining. And we actually invited you specifically to talk about an initiative called Be Healthy and Be Mobile. But before we talk about that, I did want to touch on something else. So firstly, you've been described, which I think is lovely, as a fierce advocate for women. And I think that's a lovely description. And you are globally recognized for your achievements, and especially in Zambia around the cervical elimination strategy. But I read something recently that you said a couple of years ago that really struck me as being quite profound. And it was something about the need to ensure that global cancer programs and projects are paying greater attention to national priorities and structures when they offer support to developing countries. So not just, you said, not just coming in for one meeting with the Minister of Health or the Minister of Finance, but actually talking to the professionals that work in that country. And I just thought that was really insightful. And I wonder if you think that might be why, in some ways, we haven't managed to make the most of and take the greatest advantage of some of these global initiatives to further the wider interests of women and the population in general.
So I think that came from my initial background, of course, it has been more on cervical cancer screening in Zambia. And I moved from private sector into, Ministry of Health, from Ministry of Health, and now at the WHO. And what you see when you're working on the ground really is that there's so many meetings that happen, and you hear of a meeting happened and there's this partner who came in and they've gone. And of course, political advocacy cannot, and political will cannot be underplayed. But at the same time, there's this need for people who are coming for partnerships and collaboration to also spend time to understand from the people who are on the ground what is happening, what is going on. Yes, the political leaders are going to push their agenda, but for you to be able to know what works and what doesn't work, it's really important for you to understand what is going on. From a nurse who's screening every day, what are your challenges? What do you experience? What is going on? Because that gives you an idea of where you need to go. You're talking to the civil society. What are the challenges that the civil societies are going on? What about the people who are doing treatment, the doctors? Because all they hear is that this program has started and it has been agreed on, and sometimes they feel like this is not what we needed. So there is need to come to a mutual understanding and a mutual responsibility. And that time I was in the Ministry of Health and kind of frustrated of programs going in and out, and you've been told this has started and you are really looking for something different. This is not what the people are asking for. Yes, you've gotten the political will, but if you had spent time as a partner that wants to come into this country, you'd have gained more, and we could have agreed on the best way to use the resources. You find a lot of duplication and redundancy going on in different programs and people running in different directions. And at the end of the day, we're expecting to achieve something very massive when we are all doing our own thing. And sometimes we're all clogged in a small, in one town, in the urban area, and where the disease is happening and the other people who need to hear, nobody's going there because everybody thinks I should be here. This is where I'm going to be. So there is a need, I think, for partners to really understand, and for the countries as well, the need for a resource mapping. Where are the resources? Who's where? So that we don't keep doing the same things. And this can only happen if partners who are coming into different countries are able to go to the ground and not come in for one meeting and go out and expect, yes, we talked and we were told this is the way we should go, so that's what we're going to go and do. And the people who are actually also on the ground are frustrated by this. So I think the need for countries as well to map their resources. Who do we have there? Who is providing this service and for how long? Because sometimes a partner comes in and says, oh, I'm going to support you. What they really mean is that they'll work in one clinic for 6 months and they are gone. So if you don't get, the actual, what are you coming to do for how long, and where does your support end? So that I'll be able to tell somebody that don't worry, They are done next month, so you can also come and work there. But I will be able thinking, oh, you've gone to this district, but you actually haven't gone to the whole district. You have gone to one facility. And that needs to be very clear. So we need to start having honest conversations about collaborations and partnerships that we are having. Where does it end? Where does it come? How far? Where should you be? And who should you be talking to is important. Political buy-in, excellent. But at the same time, go ahead and get the buy-in of the people who are also going to be helping you achieve what you want to achieve.
Yeah. And Ben, I was really struck when I was looking at the kind of framework around the Global Breast Cancer Initiative, that really rang through, that it was about the importance of the contextual context of a country rather than the kind of, the global vision, but you can only really make that effective if you are putting it in the context of the professionals working and the systems in the countries that you're trying to implement your initiative in. So I think it's just such an important point, and I really love that resource mapping. It just seems like that's such a clever place to start in terms of, being really efficient with what we do and the resource that we have. So Mary, you've been listening, and you bring again a really, I think, interesting perspective and insight from IGCS, where a lot of what your kind of mission is about, supporting and training and mentoring and developing the gynecological cancer professional skills. And I know you work closely with advocates as well, including our organization. So I'm wondering, so when it comes to training, mentorship, education, from that perspective, how integrated are health professionals, and how integrated is the diagnosis and treatment of women with ovarian, cervical, endometrial cancers?
Thank you for mentioning our, flagship program is the mentorship and training program. And we have learned so much by being a part of that and doing that over the course of the last 4 years. There are a lot of common challenges that happen and occur in all resource settings. It's really something that the differences that you've learned are really parts of where there is integrated care and where there's not such great integrated care. And once we learn how to cross these service lines and bring things together, we spend a great deal of time learning from both the examples. Why is it working? But also learning from why and how, does that work? Probably one of our best examples is at our training programs, and many of those in Africa. We've learned that it's the gynecologist, the professional who's really doing the pre-invasive part of the work as well. So if we can train the surgeons who do the majority of the invasive work, who are seeing the patients, and sometimes at a pre-invasive, kind of cancer disease state, we treat them how to screen and diagnose, then maybe we can avoid that invasive treatment down the road. But as many people have said today already, when patients enter the hospital, you have one opportunity with them, right? Whether that's through their HIV screen, maybe it's through their breast screen, but at that point in time, it's important to give this holistic look and have the conversation of, well, when's the last time you've had a cervical screen? Would you have time to do this today? And if an abnormal lesion is found, then that's the time to care and treat for that patient as well. So we have spent a great deal of time and effort now in developing a pre-invasive module for our members and trainees to learn on the screening, the pre-invasive, pre-cancer treatment, because they already learned the invasive part of that treatment as well. So I think it's really important that we think about things in a holistic, integrated way. Many times you have one opportunity with that patient and have to make sometimes the best and most of it, right?
Yes, and I like that. I do think that's right. They're probably often, and I love that you actually reference high resource settings as well as low resource settings, because I actually think that this is kind of a societal kind of position that we're in, and we do we do silo body parts, and we don't make the most of the kind of one opportunity that the patient or the individual or woman comes into at that touch point. And so it's just a very kind of interesting insight that you have. And we've talked in the past a lot about gynecologic cancers and specifically in relation to cancers where there would be unmet need. I would say ovarian cancer for sure, but for example, women with endometrial cancer. And how do you think that unmet need can be better tackled through collaboration or shared efforts across women's cancer? How would that look from the perspective of a gynecologic cancer clinician?
You know, uterine cancer, especially here in the US, is on the rise. And in fact, the mortality rates are very high and starting to equal that of ovarian cancer. So we have to begin to figure out and address this, not only in the US, but you know, across the globe. But there are socioeconomic differences that impact not only the awareness, diagnosis, and the detection of the cancers, but as gynecologic oncologists, I believe our members feel it's incredibly strong to talk about all gynecologic cancers, whether there is a stigma associated with it or not, whether there are new therapeutics and treatments, and definitely things that make patients more predisposed to one of cancer over the other. And I think that sometimes that conversation gets missed a little bit. I think it's really important that we identify our global partners and help them as well have these conversations, identify and address. We, you know, thoroughly enjoy working with WHO, UICC, WOCC. There's so many great partners in the gynecologic oncology space. I think we're fortunate that way. But I do think we have to start talking about all the gynecologic cancers. It's so important. And right now, cervix and uterine are getting probably the time that's due to them, right? There's lots more treatments. There's more therapeutics available for reoccurrence of disease and also survivorship. You know, I'm surviving these cancers now, and what do I do? Ovarian has certainly led the way along with breast in early detection, in having the conversations in survivorship. So we're excited to also talk more about endometrial and cervix cancer with those same things in mind.
Excellent. I think that's really important. So that's kind of the end of our kind of round table discussion. And so I'd like to open it up a little bit and think about some of the themes that we've heard about health literacy and, you know, making sure that we're strengthening healthcare systems rather than fragmenting them with different programs, the importance of collaboration and coordination. So I suppose my question to the panel would be, from your individual perspective, you know, are there things that you heard today, or do you have, you know, thoughts about, again, what would be some of the practical actions that an organization like the World Ovarian Cancer Coalition might take to kind of help make the most of these initiatives that we see being implemented, and indeed amazing initiatives that you're involved in? I might start.
sorry,
go ahead. No, Sharon, you go ahead.
I didn't actually end up talking about the Be Healthy, Be Mobile issue.
Yes,
and
do. Okay.
I just want to make a comment about, as we do the initiatives and the issue of leveraging mobile technologies and being able, we're talking about the young people, we're talking about, you know, even the adult women that we are advocating for. I think we need to be able to see that times are changing as well as we deal with advocacy. And there are many ways that we can get to people as well. Some are new era. We look at social media platforms. And basically, I think that the WHO Be Healthy, Be Mobile was about leveraging mobile technologies. How do we get that? And what was done, particularly the cervical cancer that was referred to in Zambia, was about what we call M cervical cancer, M awareness. Just sending SMS, you find that the financial sector has really utilized or leveraged the mobile platforms far much more than, of course, we're doing something in health, but not at the same time. You go to Kenya and M-Pesa, you come to Zimbabwe, there's, you know, EcoCash, there are all these, and people are getting messages, people are getting financial literacy, and that's behind the Be Healthy, Be Mobile. So messages were sent to women, And just to tell them there were issues of health facts, there were issues which we call good news. You know, you can prevent cervical cancer by screening. If you're between the age of 25 and 59. So we found that 18% increase uptake where we had the study area where we sent these messages to, just over time, even to the men, you know, who were in the same age group. So there's also a filtering of that information. I'm a man, but I can tell my sister about getting screened. And we found that 6% of the people who were coming, they had not come for their scheduled appointment. But when they got that message, when a brother called them, when a husband said, oh, so there is this thing called cervical cancer and women can protect themselves by going to get screened. So why don't you go and get screened? So we need to look outside the box. The last comment I would make is also, we've been talking about body parts and what happens. There's also the issue of life course. You look at me at different stages, the lifespan that I am in. So from the time there's pregnancy, there's a child is born, there's an adolescent, there's a young adult woman, there's an older woman. Let's start looking, what is it that this young adolescent needs to know at this? Is this child vaccinated? Does this girl know about HIV and how she can prevent herself, about unwanted pregnancies? If a young woman, if I'm coming in, you're going to look, okay, we're going to talk about issues of cervical cancer. There's issues of breast cancer. There's issues of ovarian cancer. Let me talk to this woman also about issues of menopause. She's coming in and she needs to know these things. So look at me at the time that I am in my life and try to figure out what health services do I need? And that will also be able to bring us into integration. So let's look at the course that I'm taking in my life and what stage I am in and design programs which will be able to, and then we are going to break these silos because we're looking at me coming as a young teenager, me coming as an elderly woman, because we leave them out of these things because they are not coming to the facilities as often. So integration, life's course, and the WHO clearly wants to see that we look at people through a lifespan. Thank you.
Thank you, Sharon. And I love the, I do love the Be Healthy, Be Mobile. And I just think the whole opportunity and the potential around social media and technology that is so light on its feet and sits outside of the health service. And in some ways, for many women, I'd probably include myself, you know, I am probably more receptive to some of those messages coming through those mediums than, you know, our traditional health promotion, health, you know, health education messages. So I think it's fabulous, and you know, and I love the kind of principle behind the program about creating, I think, capacity for governments to be able to share those health messages. And Lauren, while we're talking about this, because I also wanted to share your cancer guide apps, because again, a really fantastic example of how technology actually, with, I'm not saying little cost, but you know, is you know, quite an efficient way to really to get these messages far and wide.
Thanks. Yeah, the app was born of probably a perfect storm of occurrences. First of all, it was my pet peeve that anytime someone wants to do something within any health thing, they create a pamphlet with education and awareness of signs and symptoms. If we could add up all the money that we'd spent on these pamphlets through just my 13 years of doing this, we could solve a lot of problems. And the second thing was hearing the issues that in a country or like South Africa and Sub-Saharan, where there are so many different cultures and languages and availability and access to healthcare and agency in women, you know, hearing those problems over the last 13 years about having 12 languages and that we did. And then the final thing was my 4-year-old niece who'd recently been chastised because she'd stolen my red lipstick to put on. And I told her that she needed to take this piece of paper and go and draw something. And she looked at me with her perfectly red lips that she'd put on and told me, you know, a tree died for that. and then asked me for my cell phone. It came to us that we could create a repository of education material and interactive screening and self-observation that guided the patient through that, but not so that they were seeing what they needed in terms of the signs and symptoms, hearing it in the language, being able to see it, and then taking that and answering questions that they could then use when approaching their healthcare provider to say, these are the symptoms that I've had over the months, and that gave them a mechanism of entering a healthcare system that sometimes isn't very open to something, as we've heard, that isn't the usual TB or HIV testing. So we created My Cancer app, and we've worked over the last 18 months. We're currently, it's just on cervical cancer and breast cancer. With more funding, we hope to do all the cancers. And our best way that we've seen in spreading it is the word of mouth, as people were storytellers. And for us, the word of mouth holds some of the most beneficial advice and credible advice. So we've actually worked amongst patients to tell their communities about it, so that they can say that they've been, and if they'd had this tool, they could have been, their health could have been seen earlier.
I love it. I think it's just a very empowering and innovative just way of getting those messages across. So thank you very much for sharing that. And I have been on and I have worked my way through the app. It's very helpful and very informative. So it's an excellent tool. So we have about 4 minutes, and I do want yeah, it's brilliant. And I want to give everyone a chance to sort of have a last word or last thought, or, we always say, what would you, what advice would you give us, or, what can we do as a coalition? So Ben, I'll come back to you. I'll start with you your last thoughts.
Well, I thought Sharon's point about the world is changing was really right on track. And we also are looking at developing new technologies and approaches that are better than what we did before. And we saw this, we aren't just doing the pap smear and reproducing that. We're thinking of new tools. Part of getting industry is to think about innovation that moves towards equity. And not just it's a better tool. The point about integrating the gynecological cancers, I think, is very important, and having systems that can address that. And there is within WHO a predecessor to that, which is the Childhood Cancer Initiative, because they're looking at all of the childhood cancers as a group. It's part of this holistic thinking going forward within the system. Thank you.
Thank you. Thank you. Nicoletta, any last thoughts? You're on mute, I think. It's okay. We have about 2 minutes. That's okay.
The topic is very complicated. The diseases are so many, each of them are very complicated. And we have to deal with a huge number of people, with the world. I think the technology could be one way toward the solution, but not the only one, because sometimes technology is user-friendly, but it's also complicated. And we have from one side complicated argument to be communicate with sometimes complicated technologies. And so I don't know if it's better to go forward or to reflect if something of the past could be useful also today.
Yeah.
I don't know.
It may not be one size fits all.
It's very complicated. Yeah. And moreover, think to the precision medicine. We do not talk so long about organ, but we were talking genetics, hereditary. So everything could change in a very dramatic way. So the best way is go on and talking between
Thank
us
you. I
and
agree.
try to find some solution altogether.
Thank you. And Maud, last thoughts?
Yeah, my takeaway, I think, let me just talk about two. It's the leveraging on technology and the urgency to involve the young adults, and all about the lifespan of a woman, whether she should be involved in everything and messages should keep going. And on the technology, it would really help to get messages through phones where women could understand more about the signs and symptoms, as others have already said. So it's quite important because that also reduces the resource burden of walking all the time, going to the health centers, which can be at quite some distances, and also natural. They don't have to spend that much. So technology is one thing we could look at on leveraging. It might not only be phones, but maybe radios. Why? Because in
Radio
the
is
kind of
really
working, most of them cannot afford to have phones. But maybe what can we put on radio? Because the radios are things which they listen to all the time. So just leveraging on technology and the urgency to get to young adults.
Yes, I agree. Thank you, Maud.
It sounds so old school, but radio is amazing, right?
I know. It's true.
What a
It's
great
actually, it's a very
opportunity.
important point. We sort of
Yes.
overlook radio, but it is actually a really central
Totally.
communications mode. And Sharon, would you, any last thoughts?
I'm so sorry, and taking time to.
It's okay.
And I think Maud has said it. Different avenues that are available for us to, and we have to consider where they are, of, the locality. Is this a rural area? Is it, what will work for this, the language that they will understand is better. We also need to look into communities, and it has worked, to look at voices of influence. Some are that have been existing for a long time, social cultural structures that have been there and respected in the community. Could be traditional marriage counselors, could be religious.
Yes.
Need to find those and build on them. And of course, we see the also needing new ways of being reached. They will not read a pamphlet as much as maybe I can read it. They will not listen to the radio. They'll be more on their phone. So let's reach people for them. And that cause that when we go in a country, find out what the needs are and intervene according to the need for that locality.
Thank you.
Thank you
Thank
so
you.
much.
Miriam, we were a little over, but I think it's important we all have a last say. Miriam?
Sure. And I think there's been excellent points around the need for innovations. I think my point is more to your question around what can the World Cancer Ovarian Coalition do going forward. And I think perhaps there is an opportunity in the women's health and gynae communities to actually sort of map out what are the resources that we have, because we don't actually know that. We don't necessarily know what Mary's doing, what Lauren's doing. I'm just getting brilliant ideas just from this discussion. So really looking at how do we map out that collective global expertise, and then perhaps sort of look at based on the needs that we identify in particular environments, how do we then match our skill set to help support or bring up deficits perhaps in different areas? And that's an opportunity for shared learning. So I think that's one of the aspects.
Really
and then point is also really around multi-sectoral approaches. We know that pushing health on its own, the health agenda doesn't really take us very far, and it's really diversifying our portfolio to think about how do we bring in finance, how do we bring in education, how do we bring in people who are concerned with women, because there's been a bit of that dichotomy between women's cancers and women's health. How do we get that common intersect? And so those would be my two sort of thoughts around how to sort of push the needle
Thank
forward.
you. That's really excellent. And Mary?
Yeah, I've learned so much today. I always do in these panels. It broadens my thinking. It would be easy and nice if it was a one size fits all, but it's not. So how do we fit the needs of everyone, remain within the confines of financially doable, technology available, We too have given some thought, Miriam, to this, kind of international repository of information. So if there are things happening in some parts of the world, we don't have to replicate that everywhere. Let's learn what others are doing. And I do think it is going to be an important step moving forward in the elimination of cervix cancer, is to better understand within those 3 pillars what's happening so that we can learn from others, not reinvent the wheel, but replicate and take it from there. So it's been a real pleasure. I really enjoy all of you very much.
Thank you. And Lauren? Oh, you're on mute, I think.
I think that we remember to listen to the voices we hear, that whether it's the 4-year-old that is telling us that the piece of paper will kill a tree, or the patient telling us that they're not just a knee or an eye or a lymphoma or an ovary. And I think that if we truly listen to those voices, the solutions are there. We just have to listen.
I think that's a brilliant way to end in a very astute observation. So thank you. I just want to, on behalf of the coalition, thank all of you for making time from your busy days, and just really thoughtful discussion. So definitely we learned a lot, and we'll take a lot away from this. So thank you all so much.